Dr. Ravindran, sir. Yeah, please answer. One last comment and then.
Yeah, I think one of the point which actually sir really made is it's really case dependent basis. If the case where you feel the person is capable to handle further, you can let go and see. But if you feel at any point you have to take over, see, being a training institute, we shouldn't be in a fact that okay, it's fine, it's a training institute, complications happen, chalta hai. We don't monitor. That is completely wrong. We have to, at the end of the month, you have to see how many cases of complication are happening. Then we have to monitor, audit. Why was the complication happening? I mean, was the training, it shouldn't happen. Actually, normally at the end, the outcome should be good, no matter what, even if it is a training institute. So we have to really be aware and look into it, definitely.
Thank you, sir. I'd like to now invite the boss himself, Dr. Ravindran, sir. And we are really very, very fortunate and lucky to have you, sir, here as the Chief of Ravindran Hospitals, and I've had first-hand experience as to how well he teaches and the kind of inspiration he gives it to all of us. Thank you so much, sir, for being here. Looking forward to hearing you.
Yeah, thanks for this opportunity. And it's also good to speak to all the experts and faculty members here on the training part of it. Dr. Chitra actually asked me to talk how the camp activities can be enhanced or used to enhance the quality of the training. I mean, it's really important. No? There are, as ophthalmologists, our duty is to see how do we eliminate the needless blindness, especially due to cataract. But if you look at the studies which have looked at the barriers for cataract surgery, they've seen that the poor surgical outcome and the inadequate access are the two major impediments for people to avail the surgeries, especially in a low resource settings. So one is we need to improve the surgical capacity by adding additional surgeons and also by providing equipment that will address these two. And again, it's also about the success of the whole thing also depends upon the surgical quality. I mean, this is where the volume really matters. Surgical volume gives the surgeons a better manual dexterity, it improves the surgical skills. Because as the volume increases, it also helps to bring down the surgical complications and resurgeries. And if it all can be done in a kind of a controlled environment, it's always really helps. And here I would like to show this, this very crowded slide. If you see this first part of the graph, this is the first 100 surgeries done by postgraduates. And the first graph, as you can see, here is about intraoperative complications. These are about post-operative complications. These are about the resurgeries. The first 100 surgeries we have seen, it's around about 4.5% the intraoperative complication. The next 100 surgeries drops down to 2.5. Then the third 100 surgeries drops down below 2.2. Then on the fourth surgery, the fourth 100 drops to less than 2%. By the time when they come to 600 surgeries, the incidence of the complication drops to close to 1% or less. So the volume really matters. Similarly, the post-operative complications also reduces, but we haven't seen a great impact on the resurgeries. So, and the volume also really matters, and in Aravind we are fortunate to have a large volume of patients, not only coming through the camp, but there is also a walk-in free patients. So initially, whatever the training happens, it's all the free direct walk-in patients who would be able to come for regular follow-up because they are all from the nearby areas, and in the camp surgeries, they are able to do only when the complication rates are low. And while the volume is important, a structured, scientifically based surgical training program is also equally very, very important, which will include the wet lab training, because the fellows start there, especially in the care, it's all talking about the fellows. The surgical training starts in the third month. Usually they start off with their wet lab training, followed by intense surgical training under supervision. So, and the wet lab, they spend enough time. We have the simulators, we have the bow ties, and we also have ways how we can bring the hand-eye coordination. All this is done to minimize the complications. And typically they start with small incision surgery in the third or fourth month of fellowship. They start with step surgeries. When we talk about step surgeries, we talk about what they do on first day. Normally start with connective flap section and even maybe suturing. And the second and third day they do those first two steps and do the capsulotomy. And the fourth day they do this. When they do only minimum steps, probably they do it not on the one patient, maybe 3 or 4 patients. So by the time they come to the last day of the training or the 7 days, they probably operate on one patient. And they are able to independently do all the steps in 2 weeks. And all the surgeries are done under supervision. And here the only difference is the whole thing is packed. All the training is done with the 1 month. Every day these people get to go to the theatre. Every day of the month they go to the theatre. And that helps really to improve their minimize their complication rate, build them the confidence so that they can be trained further as with minimal supervision. During this period, we also have a dedicated trainer, usually a first year consultant or a senior fellow. They spend that 1 month with the fellow for the whole of the initial training. These people stay with this particular person for both the morning to evening. So as this constant interaction also really helps in the trainings. And we also not only teach them but also evaluate all the post-operative. So, and we also have a way of monitoring, having a log book and a daily meeting with the post coordinator and also video recording of the cases, usually the 3rd week and again in the 8th week. And we also use this ICO's ophthalmology surgical competence assessment rubrics, we call it SASCA, and for at least the first 25 to 30 cases to see before by this time they are usually independent and do all of them. And these staff, they also attend the weekly complication audit meetings for them to really understand at what step it happens and how it was managed and what was the visual outcome at the time of discharge. So all these details are all discussed. The person who made the complication and who managed all will be there, and this is a great learning for them. And coming back to the camp really brings a state that really helps in the training. As I said earlier, it improves everything. But involving the not just in surgery, but in the actual outreach work, as it was mentioned earlier talk also, they really understand the access challenges of the underserved populations. And this understanding also will probably help them to do this, take up this work later on. And they keep doing the campsite without any equipment, assessing the patient, trying to choose the patient based on visual criteria and the type of cataract and the need for avoiding complex cases because these patients need regular follow-up to be referred to the hospital. And also evaluating the co-existing systemic diseases. Today we see about 40 to 50% of all the patients who even come to the camp have diabetes or hypertension, and how do we manage these patients also becomes important. Again, these training these patients in the base hospital, they've seen it in the base camp. They also do the screening with the equipments in the hospital, really helps them to understand the whole thing better. And again, as the initial training part really helps them to minimize the complications. By the 1 month when they are able to minimize the complication. We also facilitate operating on 2 tables so that they be able to do volumes. Usually these fellows after about 18 months they will be able to do at least 25 to 30 seconds. And again, let us talk about complication management. We have a structured 2-day training program for these people as they finish the 1 month of their training program. They have 2 days of kind of a seminar, in-house seminar, for them to understand how to do the surgical management. They are taught how to do the anti-protective in a much possible. And what is also really makes them a good surgeon is when they start playing the role of a trainer. So when they are the senior fellows, they have done at least about 20-21 months of fellowship. They spend at least 1 month as a trainer for the postgraduates. It really helps them to understand the whole surgical steps and taking lectures further their knowledge, and that here they also have an opportunity to manage the complication of the trainings. So all of that completes the whole cycle. And we also have a system where we capture all the information about the surgery and complication. We also do a benchmarking, and that is available for these people to look at on any time, any day. They'll be able to look at their data with others' data. And as you can see, nearly about 60% of the surgeries are done by the medical officers for the small incision, which is mainly the patients would come from the camp and the free hospital. But nearly 25% of the volume is done by about 60 to 70 fellows, averaging about 400 to 500 surgeries. And here I'm just showing the data of the people. These are the actual real data for the people who are there now. If you see from the row from 11 to 15, they are the people who are in the first 6 months. There you can see the complication rates of 7%, 3%, 5%. But then as they cross that period, then it comes down to about 2 to 3%. And once they cross the threshold of about 900 surgeries, you can see that it comes to about 1%. But there is in between even the complications are less, where they don't operate complex cases. As the volume increases, they also start doing complex surgeries, again the complication rate increases. Just to conclude, this kind of a scientifically structured training program, if it is supplemented with the volume, you'll be able to develop a confident surgeon, and they are all aware of the role and usefulness of the paramedical staff, the community work, and we also talk about practice management. They understand the social marketing part of it, and when they go for the camp, they also lead that team, and when they are a trainer, they also lead that training team. So all that develops their leadership capacity as well. And the whole key lies in an adequate pre-surgical training, which is for the wet lab, learning in a step pattern, and the close faculty supervision. All of that will really help in shaping these surgeons who will go out and hopefully able to take care of the blindness and help in achieving the goal of eliminating needless blindness. Thank you.
Incredible presentation, sir, as always. One question to you and Dr. Vijaya ma'am also. Ma'am, in all these years, have you ever come across an incident where you had to change your program? For example, in cataract surgical training, for the trainees, did you need to make any change in the training program?
Yeah, we always.
Or in all these years, the surgical techniques have evolved. So, or has it been the same over the last 5 years? 10 years?
No, constantly the changes has to be there. For example, recently we have a simulator, the health simulator, that really helps now. In addition to the regular training, the lab training, you also need to put them on 10 days of training on simulator. That really helps. Because there is also feedback mechanism, that helps them to understand the whole process. Then as they make this decision badly, what kind of complications they get, there's a feedback that comes from the patient. All that really helps.
Very good presentation, and to your question, maybe I want to make a small comment about this presentation. Yes, we have changed over a period of time. Wetland has come in, simulators have come in, and initially there is a lot of emphasis was given to the ECC AIOCs, then SCCs, then the paper investigation. Now, most of the time they start up with the SCCs and then move on to the paper investigation. But in our setup, we still give importance to some ECC AIOCs because we want them to be well versed with the suturing techniques, and also we insist on practicing the suturing skills in the wet lab. And coming to a quick comment, and it's great to see the volumes the student gets, and it's not possible for every student to go through that kind of experience to become good surgeons. So what I strongly believe in is, like Subhas has said, that you create a pattern. This is the way it has to be done. Step 1, 2, 3, 4, 5, 6, 7. Don't deviate from it. And be there with the student all the time till they do those steps properly. And it is really holding the hands doing it. And even with this, when you do that, even with the 25 to 30, you will see a well-trained surgeon coming out. I think ultimately it boils down to your needs, what you have, what you can offer, and how you can make it surgeon.
Thank you so much.